Good morning, everyone. So this is a session on which we are trying to demystify extreme VR surgery and give tips and tricks on how to handle these very, very complex situations. So without wasting one time, we are going to cover a whole gamut of retinal diseases. We are very privileged to have Dr. Dhanashree Atra, Senior Consultant, Shankar Netralaya, and Dr. Gagan Bhatia here with us. He's at Shawfire Center. So I'll like to start with the talk on proliferative diabetic retinopathy. So Dr. Gagan will be giving the first talk on PDR.
So good morning, everybody. It's a pleasure to be here. And first of all, I would like to thank, as being the first speaker, I'd like to thank the organizing committee of AIOSC for giving us this opportunity. So I would be talking today about PDR, and it is one of the most challenging surgeries that at least I feel I've learned through the years. So as we all know, PDR is basically a proliferative vascular retinopathy. And what differentiates it from simple PVR is basically the vascular nails, which are basically the vascular connections between the retina and the fibrovascular tissue. Then it is the hemorrhage. So hemorrhage is also another component which plays a very crucial role in understanding PDR pathoanatomy. And the third most important thing is vitroschisis. I think this is one element of PDR which basically makes a surgery difficult and easy. It is very important to understand vitroschisis because it is basically it helps us to get into the right plane of dissection, and that is extremely crucial and critical to make a very simple case, keep it simple or make it extremely difficult. So we'll just go through this small animation. So as we all know that the vitreous is composed of the vitreous gel and the vitreous cortex. And as I had mentioned earlier, hemorrhage, which creates a cleavage plane into the vitreous cortex, cleaving it into two leaves, the anterior leaf of the vitreous cortex and the posterior leaf. And it is very important to understand this phenomena because this is what makes dissection simple. So the green arrows point towards the anterior leaf and the blue arrows towards the posterior leaf, and it is very critical that we understand this so that we are able to get between the or under the blue arrows, which is the plane between the retina and the vitroschisis. When we come across diabetic vitrectomy, I think these are the points which are kind of highlighted or which we need to kind of go one by one and understand. So pre-op anti-VEGF, I think, is one of the most commonly used platform, I think, which is used extensively, and it makes the field quite, bloodless and atraumatic. Combining phacoemulsification with diabetic vitrectomies is a good idea because you can very easily tackle anterior prolifs, and also gives us a good, base excision and a good view to tackle these membranes. A normal PDR vitrectomy, you would obviously need to create an area of separation in the posterior leaf of the vitreous cortex, and this is usually found in the mid-periphery or at the posterior pole. So going through this video, this is a very typical can opener technique where you find your cleavage plane, and after creating a cleavage plane, you basically can extend this and go all around, separating the posterior prolif from its anterior extensions. And so this would be a very classical way of entering into the posterior hyaloid, or a can opener technique that we do understand and go through. And till you are able to finally complete the entry into the posterior hyaloid 360 degrees. In this next video, we understood the pathoanatomy through enswepsosity, and then we created the cleavage plane again in the temporal periphery. And because there was very tight attachments of the membrane anteriorly, there was a point where we had to stop. And then this scleral depression helps us to again find our cleavage plane. With the cutter suction, we are able to kind of pull the posterior hyaloid a bit and then create a cleavage plane there. And with the help of dissection itself and very carefully separating the anterior extensions of the membrane, we complete the entry into the hyaloid. In this case, this was a morbid condition where it was all stuck. So we take a needle and make a entry into the posterior hyaloid at the posterior plole. So the difference is that in this case, we are going from posterior to anterior, unlike others where we went from anterior to posterior. And then again, we complete our entry into the hyaloid. 360 degrees. Now coming to the next component, which is bimanual surgery. I think bimanual surgery helps us a lot using cutter forceps or cutter scissors. So in this case, we studied the anatomy on a Swepsos OCT pre-operatively. And you can see these vascular nails of connection and also the anterior and the posterior leaves. So bimanually, we are able to create the cleavage plane and then very carefully go dissecting all the vascular nails or the vascular connections which are there, bisect the membrane into smaller prolifs with the cutter section alone and finding that cleavage plane, and then continue our membrane dissection over the posterior pole, trimming the fibrovascular prolif along the way, and then completing a dissection in the nasal quadrant as well. And if you see that, bimanual surgery gives us a very good control, and you're very comfortably able to manage all the vascular nails and connections without causing any iatrogenic breaks. In this case, it was very important because this was a one-eyed lady, and I was, very petrified to create a break in this case because I didn't want to use any tamponade, and wanted to, give her a considerably quick recovery. This is again a technique of bimanually, taking the flute needle and a cautery in one hand, and bimanually managing all the bleeders. And then finally, we kind of dissected the superior membrane. And thankfully, there was no tamponade being used in this case ultimately. So what makes it morbid? I think it is the anterior proliferations. It is very tight adherence of the posterior hyaloid and extremely dense clotted heme, and also a detached retina. So in these cases, because you cannot really study these cases extensively, I think there are no definite rules, but I think just go by your instinct and patience, and also by the methodologies and things that you've learned through your way. So this was a case of a very extremely morbid PDR where there was no view, there was layers and layers of heme. So I think it is important to keep the cutter tip up and kind of go layer by layer, and slowly kind of identify all the structures through your way, and clear up the heme, ultimately again going to bimanual vitrectomy and managing the membranes. And ultimately this had a detached retina also, so we kind of very carefully dealt with all the membranes and completed the bimanual surgery. Again, in these cases, I think bimanual is the only way to go, which is very controlled, and you would not end up with more iatrogenic breaks and bleeders. And finally, we are able to get rid of the membrane and tackle this case to the best of our abilities, and finally put in tamponade. The other situations could be, again, anterior extensions and coexisting macular holes or combined detachments. So in this case, we had a coexisting macular hole where we first took care of the membrane, which was over the posterior pore, over the macula, and then finally did ILM blue staining. One of the tips in this case is because they're very edematous retinas, and you could very easily create a plane break. So it's important that we go from anterior to posterior, so as to not inadvertently enlarge the hole further. In this, the next video is again associated challenging situation where we had this extensive membrane anteriorly. So contact lens use is very good in these cases. And with the contact lens, you get a very clear field of view, and you're able to manage the membrane atraumatically. After the membrane is managed, then we kind of secured the posterior pole with the PFCL, and this was basically done so that we don't drag the the subhyaloid heme, the subretinal heme further down, and ultimately made a retinotomy. And if you see that first we are trying to manage the heme with a single forceps, but you get a good touch, but then again you leave it. So again in this case, I think bimanual surgery, bimanual technique helps, and with the hands-on-hand technique, the subretinal heme is kind of tackled. Yeah. So this is a case of, again, a morbid situation where you have a combined detachment. In this case, again, if you see nasally, the cleavage plane is there. The heme with a soft brush helped us to find the cleavage plane. And I've kind of realized that once you find the cleavage plane initially, I think the membrane dissection becomes extremely easy. and you're able to kind of identify all the the tags or the vascular nails, whatever you call it, and slowly you're able to kind of remove the membrane quite atraumatically. In this case, we had an inferior nasal pre-existing break, so again bimanually we kind of went around the break, trying not to extend it any further, and finally completing the case. And this was the again anterior extension of the hyaloid and kind of separated that. And finally, we completed the case with tamponade. So I think to summarize, I think PDR vitrectomy, I think my take would be that understanding vitreouschisis and finding the right plane of dissection is very important. I think we should do that first and adhere to the surgical principles, whatever the case may be. I always tell everybody that, vitreous hemorrhage is not easy. It is one of the most challenging situations because you might just end up with a taut hyaloid and, that could make or break the case. And you need to be patient. I think that is very important, and be ready to alter your plan whenever. Thank you.
Thank you. It was an excellent talk with beautiful videos. Any questions? We have a very, very small audience, so we can make it more like a group discussion. If anybody wants to give their input, so what they do differently, or how often all of you doing bimanual surgery in your cases, or putting chandelier? Sir?
Sir, I am doing in a complex PDR cases. What difference I found that usually I do with the normal illumination, but when I use this chandelier, I feel a little bit low illumination while doing a bimanual. So can you help us?
Yeah, Dr. Gagan, I think Dr. Dhanashree had a similar question, so we'll club both the questions together.
See, I think as
Gagan,
well
one
as...
second. Dr. Ma'am also asked a similar question.
Yeah, this is a very good question actually. Even I was looking at your videos and admiring the illumination because even when you put the chandelier, although you can increase the intensity of the chandelier, but sometimes you don't get a very diffuse good illumination. There is some part which is lighted and some part which is dark. So what is your trick in having
Okay,
a good
the tip and
illumination?
trick, one first tip is that I think I think you should do a very good base excision before you put the chandelier, because I've seen that if the base is not very, then it illuminates that area too much. That is one. Secondly, I use a superior chandelier and sometimes an inferior nasal chandelier, depending upon where your membrane is. Like these cases obviously had all over, so I use a superior chandelier. Ma'am, as far as the illumination is concerned, my honest answer would be investment, because one is the recording systems, and secondly, these videos have been, I think 2 videos at least, the one which look really bright, are on an Artivo system. So that gives us a hybrid illumination at that time. So that really helps. And I think with 3D surgery, I think the only benefit that I've found is PDR vitrectomies, because it gives you a very good field of view and very good depth. And obviously the illumination is superb. Yeah.
Yeah, I think that's quite important. Any other questions? Okay.
Sometimes one more trick is that sometimes you can use the chandelier in a exchangeable manner. So sometimes I'll put 2 ports for chandelier, one inferiorly and one superiorly, and you can shift from inferior to superior. So once you finish one quadrant, then you shift the chandelier to the other quadrant and finish the other. So you have equal illumination in both the quadrants, except that your number of sclerotomies will increase.
Yeah, that's the advantage of using the 25 gauge. You can put it wherever you like. So I wanted to ask Dr. Dhanashree, what is your preferred location? Because most of the time we are putting it superior, but the Egyptians who are very skilled surgeons, I've seen they're putting it inferior nasal in most of their surgeries. So how do you decide where to put the chandelier?
So it depends on where your maximum dissection is going to be. So if it is going to be superior, then I would like to put the chandelier inferior so that it will illuminate the superior area. But if the dissection is going to be inferior, then you put it superior. But as a routine, I put it at 6 o'clock because it is little convenient and it doesn't hamper your movement of the eye or other instruments. But as I said, depending on the quadrant involved, you can take a call where to put it. Okay. So next I invite Dr. Darash Shroff to speak on management of Retinal detachment. Recurrent retinal detachment.
Good morning, everyone. So I'll be speaking on recurrent retinal detachment, and Dr. Dilraj Grewal, who was not able to make it from the US, so he has sent me his PowerPoint, so I'll just briefly present that also. So please, you can also note Dr. Dilraj Grewal's talk will be given by me. The next talk also is, I'll present a second talk also after this. So recurrent RD is defined as redetachment of the retina after successful primary reattachment. So although over time we found failure rates have decreased because of advanced techniques, but this is a reality we as surgeons have to face from time to time. When can it happen? It can happen after post-pneumatic retinopexy, after buccal, or after vitrectomy with buccal. Why does it happen? Because you have ineffectively closed the brakes at the time of the surgery. You have missed the brakes when you're doing the surgery. A new break has occurred either while you're doing the surgery or after the surgery, or development of a macular hole. But the most important cause, which is a bugbear for all of us, is PVR, proliferative vitreoretinopathy. So for this, you can do a pneumoretinopexy, a revision or addition of a buccal, a vitrectomy, or do membrane peeling under oil. So recurrent RD after SB, one thing which used to be done long ago, I think Dr. DAD ma'am will also remember, is that they used to put a revision buccal, something which we don't do. So this is an optos picture of a patient who had nasal SRF because there was a misbreak in the superonasal quadrant. So this was a phakic patient, and you can see, I think he had RK also. We were not keen to go inside again. So we just put another segment of a buccal just to cover that break. You can see the previous buccal is there, but this is a revision buccal where a small segment has just been added. And you can see how nicely the post-op picture, it's fully attached, and the patient is doing well and has, I think, probably 6/6 vision, best corrected. So this is a very simple tip and trick. And pneumoretinopexy also is a very, very good tool for us to use for recurrent RD also. But the main focus of this talk is on revitrectomy. So you should do it in a stepwise. If you don't follow the first step and go in a sequence, you can mess up everything. So if there's a cataract, generally we like to do a phaco or lensectomy. If the lens is unstable, see, the most important thing is to settle the retina. All these other things come later. Hybrid vitrectomy is another tip which we have tried for cases which have got fulminant endophthalmitis or trauma. So there we put a 20 gauge infusion cannula to avoid the cannula going subretinal or into suprachoroidal space. Buccal is always a good idea in these cases because it relieves the circumferential and AP traction, and it isolates the peripheral retina from the posterior retina. When we do a revitrectomy, you need to spend a lot of time on the dissection of the membrane because anterior PVR is more common in these vitrectomized eyes. Normally, the person who's done the operation before left a large uncut vitreous skirt. After that, go back, tackle posterior PVR, subretinal band, subretinal oil, remove the ILM if required, and now after that, of course, comes the Brahmastra, the retinectomy, and a tamponade. So these are just short videos. So you can see first we are removing the oil which has been put. And here we found there was little capsular phimosis. So bimanually, view is also very important. Like if you can't see it, then you can't do it. And here the chandelier, so we just discussed with the panel. So the chandelier in this case was put inferiorly because we felt that this was the best position. So there's no one rule for everything. And you can see that napkin ring. So reason why we put the chandelier is because initially taking this band was difficult. You know, it's like a snake in the hole. You pull it, it goes back. You pull it, it goes back. So this is what we call a hand-upon-hand maneuver. So it's like taking a bucket of water out of a well. You have to pull at the rope on and on so that all these tentacles and everything comes out. And this is the settled retina with a sigh of relief. We can see everything is well attached and macula looks fairly okay. So this is exactly what I was just telling you. This one requires use of both hands to remove a bucket of water from a well. So this is how the kind of thing we used. Another thing which we thought was quite interesting is sometimes you have an occult break and you just can't. So this was a patient with a reed detachment, and you can see a lot of scars were there. So a lot of CRA patches, and we couldn't really locate the break. So we were wondering what are we going to do about it? And normally Schlerin comes out, but this was not, it was very shallow detachment. So we were not able to do it. We went with the brush. Then we thought out of the box. And there you can see with the 39 gauge cannula, we are just slowly infusing subretinal brilliant blue. And now if you just keep looking, slowly in one area where I put the red, you can see, yeah. So that's the tiny break. So that is what is causing this kind of recurrence. So this is something we don't have to use very often, but if you're really stuck, you can try this out. And patient did well. This one, they say you can leave it without laser, but since it's in a position which could be easily lasered, we did a row of laser around it. The other thing which I'm very fond of is a tug-of-war maneuver. So I think you enjoy this video. This is Dr. Gagan and me pulling at both sides. And this is just like if there's a band, you're trying to pull. So this is very good for anterior circumferential traction. So you can see this is anterior circumferential traction. And the main aim of this is to avoid large retinotomies or retinectomy. So I think this is another thing to just show you how the tug-of-war is done. And then this is one of the cases where this band is there. So you have to release this band. So if you either you kind of sacrifice all the retina anterior to this with a cutter, which we don't want to do unnecessarily. We always put a belt buckle also in such cases, but this tug-of-war maneuver helps. And this has been published by us also in the Indian Journal of Ophthalmology. If you have combined anterior and posterior PVR, first you should tackle the posterior PVR. So you can see this video. First, we're removing all these membranes which are at the posterior pole. I find the anterior PVR more difficult to tackle. We'll ask the panel also for their opinion and the audience also. But it's very important to kind of release, and also always release the epiretinal rather than go after subretinal first. So see how this is an aphakic eye. So we are not using any kind of visualization system. We are just doing it under microscope. So in the right hand, we have got scissors. Left hand, we have got forceps. And we are releasing all this traction. And then we trim it. And the retina settles well. MP under oil is also something you can use where there's posterior focal PVR in an oil-filled eye. So this is the very few situations you use it. If it's extensive, you don't. But release the oil infusion. You connect the cannula to the same brand variety of oil which was used in the first surgery. And you can just see a video. So this was a case where there was this membrane under oil causing a recurrent RD. So you can see we have tried humanly manually, and when we are pulling, we've caused a lot of traction. So again, we're very fond of the bimanual, so we put a chandelier. Now right hand is scissor, left hand is forceps. We're trying to create a plane between these, the membranes. And it does take time, so there's no shortcut. If you do, you can do it very fast also, but then you're likely to create a lot of breaks. So I think it just pays off to do it slowly. And then you do a fluid silicone oil exchange in these cases and laser to the areas which are required laser. Other thing which we are quite fond of is we are using a heavy oil for some of these very, very bad inferior cases. It's not available in India, but we have to get it from countries, especially Europe, where it's available. And they provide a good tamponade of both the inferior and the posterior normal head positioning. So you don't have to do any face down. Patients are most unhappy कि हमें उल्टा लेटना है, we have to put our head down. In this, you tell them, be comfortable. You can sit up, you can lie down normally with a pillow, and everything will be fine. So why is this so? Because oil has lower density water, it floats up, and the surface of the inferior retinal periphery is not covered. So you have a PVR soup forming in this because of the cellular proliferation there. And this causes the inferior PVR to develop. So these are some of the patients we find the Denseron very useful. But please remember, this is not a substitute for complete removal traction. And it has the availability and cost factor. So just to conclude, so if you have a recurrent RD post-vitrectomy, and if this is post-SOR removal with gas, then you have to do a revitrectomy, MP, endolaser, oil, bulb buccal, everything has to be done. But if you have in an oil-filled eye, you just have a few focal membranes, then maybe you can get away with membrane peeling under oil. If there's an inferior break and there's no PVR, then maybe you can just add a buccal or do delimiting laser. But if there's a PVR or subretinal membranes, oil, etc., then our oil removal, membrane peeling, managing the lens, relaxing retinotomy, and again oil injection is compulsory. Retinectomy is going to be covered in the next talk. Dr. Dilraj Grewal unfortunately couldn't make it from the US for this session, so I'll just present that. He sent me slides, but we can take questions before that if you would like. Thank you.
Very nice talk, Darius. Are there any questions from the audience?
Yeah, I think very good talk, Darius. I think just for the knowledge of the audience, I would, if you could just kind of describe how you use the 2023 system, and when you're doing MP under oil, is there a specific cannula system that you're using so that it doesn't slip out? Because most of the times what happens is when you're how do you infuse or keep the eye taut during
So
MP
earlier
under
we
oil?
used to, that's a good question. Earlier we used to connect the 20 gauge system, which had a sutured kind of infusion. But now what I find is quite fine is that we have 23 and 25 which have got which are valved, so the valve system is fine. So whenever you need to top it up, you can just inject little more and then continue dissection. So we don't need to have that continue. Otherwise, I remember even SN and all, we used to have it connected, and some sisters to say push the oil. But now I think because the invention of the valve cannulas, it's become more simple and easy for us.
And one more thing I would like to highlight what Darius already mentioned in his talk, that pneumoretinopexy is a good option for selected cases of recurrent retinal detachment, where particularly one of the cases which Darius showed where there was one small break which was little difficult to visualize also, but if you can see the break and if it is peripheral, if it can be cryoed, and if you think it is superior, the gas can tamponade it, then that is the very good option, non-invasive option. Most of the patients will be very happy to undergo this kind of a non-invasive option, and it has been shown to work quite well even with recurrent RD. So that I think
Yeah,
it
and
would be
also I think with, in these vitrectomized eye, you can get a good fill of oil, of gas also. So ma'am, when you do it, would you take out some saline and then inject? In a vitrectomized eye, if you're doing pneumoretinopexy, would you just like to inject the bubble of gas, or would you like to take out some saline and inject gas? Because then you can get a larger volume of the gas.
Yeah, no, but I don't take out any saline from the posterior cavity unless there is a kind of vitreous hemorrhage associated. But that would be like an OPD-FG where you remove the vitreous fluid and then inject simultaneously gas to achieve a full fill. But if you are injecting only a pure expansile gas, then there is no need to take out any fluid. If you want to reduce the intraocular pressure, maybe even an anterior chamber tap to remove some aqueous will do.
And ma'am, any tips on the number of days that you would? Yeah, I mean, one is obviously the location of the break and the amount of detachment, but anything about the number of days of recurrence?
Yes, of course. There should be no PVR. That is, of course, mandatory. But sometimes even late recurrences also you can treat with pneumoretinopexy, provided there is no PVR. But if there is PVR, then obviously the pneumoretinopexy is not going to work. So selection of a proper case is very important. So if you don't select properly, it's not going to work and it will fail. But if your selection is good, then there is no reason why it should not work.
Thank you. Can I, AV team, excuse me? You can put on this next. So because this actually topic flows into the other one, I thought to just speak about. So this is a talk from Dr. Dilraj Grewal, who is at Duke University in the US. So he couldn't make it. So he just sent me. So this is how the talk goes. We'll just talk a little bit about the basics in the beginning. So like all those maneuvers we showed in the last talk, if they don't work, so this is like the Brahmastra. So this is like what we can, in our armamentarium, this is the next level. So this was initially described as long ago as the 1980s by Dr. Robert McAma, who is like the father of vitreous surgery. And it's very important that this should be sufficient. The cuts, so this is when you cut the retina to make it free and mobilize it. So the cut should be large and sufficient. When you're going about it, be generous about it. How to perform? So you can have a circumferential or a radial shortening. So both these can be tackled, but what is most important is you need to extend the retinectomy into the normal retina also, about 30 degrees of normal. So don't be satisfied with just tackling the area of concern. If you do that, it might fail. You have to go into normal retina also to relax it sufficiently to get a good reattachment. So these are also areas, basically, again, anterior contraction, which are not relieved. So this is going familiar thing that the anterior PVR is a bugbear, which is very difficult to tackle. So you have to extend it into the unaffected area to be able to settle the retina. If there's a focal retinal incarceration, first I would recommend that we release it. You always do less invasive things first, and then if it still doesn't settle, you might need a localized retinectomy. If you have fold edges of a GRT, these are also an area where you can excise it and release it. And it's important to avoid slippage by always keeping the flute needle at the edge of the break, so keep on drying it when we are doing this maneuver. So I think there's a patient who is a 44-year-old phakic female with macula of RD, very, very poor vision. So this is the surgical video which he shared with us. So I think the lensectomy is done. He's removing the capsule now. And you can see it's a very, very bad case. I mean, there's extensive PVR, there's a huge tear. And this is a bimanual surgery with the spatula and the forceps. The spatula we don't use so much here. Maybe in the US they're using this. I don't know. We are not using this so much. But he's now cauterizing the edges. So it's good to cauterize this so that the bleeders don't happen from the retinal vessels. And area which is anterior, it's important to excise it completely. Because if you leave it, it goes and attaches to ciliary body, and then there's always some hypotony in these eyes. So this is the 360 retinotomy, and then I think in the previous operation some PFO is there. So this is the subretinal PFO which is being removed. So, and he's trying to look for anything underneath, which is any PFO left. And so it's important to, if you're going something so aggressive, you have to go all the way. And now see, it's very interesting. He's going on putting PFO and he's going on sliding off. So what does this mean? Why is this PFCL not staying? Anybody has any ideas? Why? Where's the, yeah, so basically if your epiretinal is clear, you have to go. So there could be like a napkin ring or some membranes which are behind the retina, which are holding this thing like a tight ring. So once those are removed, so you have to look above the retina, you have to go and look below the retina. So only once everything is removed, in fact it has settled, but doesn't look so great. Post-op day also it's like a tiny sliver, but fortunately patient did well at 1 year and got 20/400 vision. So this is the Optos picture at 1 year. The role of adding a scleral buckle is also quite important. So basically, this supports the horns of the edge. So 360, of course, we don't put a scleral buckle in 360, but if there's a limited retinectomy, it's always a good idea. If there's a phakic patient, we are have a low threshold for adding a buckle. It reverses the direction of the vector force perpendicular to eyeball, increases the curvature of radiation, and this gives a good kind of support for the retina. The vector forces get adjusted, and it helps to settle the retina, and the horns of the retinotomy should be on the crest, not the trough of the buckle. Some people are advocating primary retinectomy for PVR, but I will not, I mean, this is just for information. I don't say that this should be done. So even after retinectomy, and you can still have a recurrent retinal detachment. So that is one of the most disheartening situations. You're really done everything, you feel you've used the ultimate weapon, and then you have it. So you need to know why it could happen. There could be fibrosis of the retinectomy edge, inadequate, so it should be adequate. Like we said, you go into the normal retina, don't try to be stingy with it. There could be an ERM which can need another surgery to remove. The anterior PVR, we've gone on and on in the first talk and the second talk that you need to tackle that. And severe folding and recurrent PVR is something is beyond your control. So thank you so much for your patient listening, and we can just have a small discussion on both the talks. Yeah, yeah.
So you can come on the mic there, sir. Mic.
Yeah, sorry, what is? Okay, I'll just put that on. Audiovisual, can we just go back to the slides, please? This one, sir? Next. One second. Mm-hmm. Yeah, maybe little posterior, but main thing it should be, but it is giving, basically the posterior part should get coverage. So in this case, it is getting, I think, yeah, maybe little bit posterior, but otherwise it's okay. Yeah. Yeah, that's true. That's why it's very important that it covers it adequately. So that's of course in a vitrectomy we don't localize, but otherwise that's why in scleral buckling we are very particular about localizing the break, because it can leak from the anterior part, it can leak from posterior part. So yes.
So actually, if you have put a scleral buckle, there may not be any need to do retinectomy, because your scleral buckle is anyway going to indent the sclera and cause the retina to get adherent to the retina. But if at all you are planning to do a retinectomy, then very posterior retinectomy also will not work, because it will slip on the buccal slope.
Yes.
And if the edge goes under the buccal slope, then you will not be able to even laser this thing. So it would be good to do it on the buccal, the maximum height of the buccal.
Yeah, and sometimes if we do a 360 RR, we actually remove the belt buckle at the end of the surgery.
Similar to what Madam was saying, that in today's time when you can manage a very decent vitrectomy, even in the anterior vitreous, and if you are planning a RR, there are very, very, very few indications where you would actually want to put a buckle to support the RR edge or a retinectomy edge. Very, very uncommon that you would want to do that. Because usually then the way you are saying, and if you want to be able to laser the edge of the RR, your buckle would have to be fairly posterior. That itself is not something which is very physiologic or easy to do.
Maybe we have to put it little oblique, quite oblique, I should say.
Just don't put it.
Huh? That won't
Just
work.
don't put it. You probably,
You don't need.
in most of the cases, you probably have to extend the RR edge a little more on either side, and you're able to manage without putting a buckle where you've already planned an RR.
Yeah. Because then it's redundant actually for those. Any other comments or tips or tricks, Dr. Abhishek, Dr. Ratra?
So if I can give a few tips is, very often when you start doing a vitrectomy, a retina which looks very contracted, if you do a good membrane dissection and membrane removal, the retina can become quite mobile. And you will be surprised to see that you may not need to do any retinotomy or retinectomy in such a retina at all. So first, most important is to do a good membrane removal. Even when you are planning to do a retinectomy, it is always good to remove all the membranes on the retina. If you do not do that, your retinectomy is going to fail because it will contract again. And moreover, you will not be able to flatten the retina. So you see the LPFC will, it'll roll over the retinotomy edge and will go subretinal. Sometimes when you have done the retinotomy prematurely before removing the membrane, the retina will just close like an umbrella, and there is no way you can open the retina after that. So never do the mistake of doing premature retinectomy. Always do membrane peeling first, remove all the membranes, make the retina as much mobile as possible, then take a call about where to do retinotomy and how much retinotomy to do. And second thing is, always remove the membranes posteriorly first and then anteriorly. So if you remove the anterior membranes first and the anterior retina becomes mobile, then it is difficult for you to reach posteriorly and do the posterior dissection. So it is good to do the posterior dissection first and then come anteriorly. And once the posterior retina becomes a little bit mobile, you can put a bubble of LPFC to keep it little stable. So it will also help you in doing the rest of the dissection anteriorly.
How often do the panelists do ILM peeling in these cases? Is it necessary to remove ILM in these patients? All the time, sometimes, or never? And second question is, along with this, what technique do you use for staining? because I think there are a lot of innovations. Some people are putting PFCL bubble and using a brush needle to put the dye under that. So role of ILM peeling.
Yeah, ILM peeling, I would say that I don't believe in doing ILM peeling in all the cases. ILM peeling you can reserve for say very refractory patients with a large macular hole, or if you have a very high myopic patient with a lot of foveoschisis or taut retina at the posterior pole, those patients you can do ILM peeling, because ILM peeling in a retinal detachment is quite difficult. Despite your years of experience, you may still have to struggle, and staining and everything is very difficult. So you can stain under LPFC, and you can even do the ILM peeling under LPFC, but it is difficult as compared to a normal ILM peeling that you would do. So you have to take a call based on your expertise and whether it is really necessary or no.
Dr. Abhishek, anything on that?
So one of the things is that along with the epiretinal membrane peeling in PVR, it's also quite important to do subretinal peeling. Sometimes you just, what is visible to you is just a band, and the folds are not really settling. If you do a 180 or 200 degree RR fold over the retina, you may have sheets of subretinal tissue, and the minute you remove that, the retina opens up very, very well. So that is something that you need to be aware of. If you've done epiretinal membrane clearing and still there are folds, still the retina looks contracted, this is something that I try and has worked for me. I almost never do staining after putting the PFCL. Even if I want to use PFCL for peeling, I'd always stain first, and then, because doing the brushing thing, first of all, you're inducing trauma, and it will never be as uniform as it is. Almost always before starting the peeling at the posterior pole, I put in dye. Whether I want to peel ILM or not is a different question. It highlights, due to its negative staining,
Yes.
it highlights the ERM, makes me well aware of from where I want to start or what area would be a easier, I would say, choice to initiate the peeling. So I almost 100% of the time stain. And one thing about ERM peeling in PVR cases, don't stain, staining once is not usually enough. Sometimes in the same case, we stain 4 or 5 times.
So don't feel shy
multiple
to stain
times.
it again.
Pardon?
Don't feel shy to stain again.
Yeah, don't
some
feel
people
shy to
hesitant
stain again. Sometimes you need to stain multiple times because these cases take time. And by the way, brilliant blue, sometimes the color fades with the, sometimes. So you can again stain. Sometimes you've removed a membrane thinking that it is ILM or sometimes thin ERM.
Yeah.
You stain again, you'll see that there is another membrane underneath it. So stain multiple times when you have bad PVR. There's nothing that you are going to lose.
I think it basically you ensure that hyaloid comes out with this. Even ILM, sometimes ma'am says it's not really required, but you just take out a strip of ILM. There's no publication on this as such. But then you are sure that you got the posterior hyaloid, because these are not like cases which have been operated 3-4 times and they've come to us. So we want to make sure they settle at that time. We don't want to fail. So that's why we go all out and do some of these things.
I think one point that I would like to add is that, in PVR, in recurrent detachment, I think even with the best of hands, going behind the hyaloid is very important, because in most cases you will find the hyaloid attached. So even if you know the whole history, or if you're even the primary surgeon and you feel that you've done everything, I think stuck hyaloid is always one of the major causes to see. And I think, as Dr. Darius just mentioned, I think highlighting with that ILM blue dye does kind of help to ascertain that you've kind of tackled the hyaloid properly.
Yeah, one final point about retinectomy. Do clear the peripheral vitreous very well before doing retinectomy. The most common cause of failure that I have seen after an RR is a strand or a band of vitreous attached to the RR membrane, which later on contracts and lifts off the retina.
Dr. Abhishek, just come here. There's a question, but just put your laptop in. Dr. Abhishek, laptop connect. So we can take a question now, please.
Sir, this is related to your presentation. Okay. So if there's a case of recurrent retinal detachment with silicone oil in situ, how do you really deal with it? Do you remove the silicone oil and then deal with the recurrent RD, or do you do?
So like I showed in that algorithm, basically if you have recurrent RD and there's focal membranes, or supposing you have a little bit of inferior fluid, then there are two options. One is you can do it under oil, a limited retinopathy, or you do membrane peeling under oil. So that's a very localized area which is affected. Or if there's a little fluid in a small, tiny pocket, you can just do a little bit of laser and you can leave it alone also. It's not necessary to go after it. But if it's extensive, then you must go the full way, take out the oil, and then do a revitrectomy.
Then you don't attach the infusion line at all. Just make 2 ports and just
Yes,
peel the
yes. If you're doing MP under oil, then what you can do is you just have 2 ports with the valve cannulas. If you are more comfortable 23, that's also fine, 23, 25. Then you keep that oil ready so that eye does not become soft, and you try to use a relatively new cannula, maybe, I mean, one time or something, because we all are reusing maybe. But you keep putting the oil, keep forming the eye, and then you, with one hand you have the light, one hand you have the forceps, and you keep on peeling, and when the eye feels little soft, you can re-inject the oil through that port.
Thank you, sir.
There is also an option of having silicone oil infusion.
Yes.
Yeah, yeah.
So we use the silicone oil infusion itself. So you have the infusion cannula, which is connected to a syringe with silicone oil. So that as the silicone oil, seeps out of the eye and the eye becomes hypotonous, you can inject a little bit oil.
Or the sister can inject. You have the assistant.
Sir,
can inject.
I have one question, sir. Once doing membrane peeling under oil, after removing the membranes, how do you drain that subretinal fluid?
Yeah, that's a good question. So basically, in that condition, you have to have the oil infusion. So you inject the oil, make the eye tight, and then you take the flute needle near the break. So you have silicone oil fluid exchange. So when the eye becomes a little tight, there will be pressure, and then once you take the flute near the break, there has to be a break there. If there's no there will be obviously a break, but if the break is very anterior, you can even make a posterior R1. These are conditions, make a retinotomy posteriorly, and put the flute needle there, then fill oil, and then with the pressure, the retina will go back, and the fluid will come out of the retinotomy.
Sir,
Sometimes there is no break and it's more like a TRD configuration.
Yes,
There you
sir.
don't need to drain.
Yes, sir.
Just remove the membrane, it's fine.
If membrane is slightly anterior and fluid is slightly posterior, it has gone to the posterior pole because of the lying down position of the patient. In that case, can we put PFCL bubble also, or how can we train?
No,
No,
then
if you want to
make
do
a-
all that, then if you want to do all those maneuvers, then you remove the oil and do it like a proper case.
You can
Then you
make
can't
a-
do it under oil. Then
You
have
can
to do
make
it
a
like
retinotomy under oil also. With the oil infusion, you can make
Yeah.
a posterior retinotomy and
that
drain
you can
it.
do, but
But don't try to put
Don't try to put-
PFCL in a oil-filled eye.
because
Just do not try to do that.
then you get that sticky oil and all, and it can mix. And then to remove that is a nightmare. I think we've all gone through that, so don't do that.
Thank you.
So can we do this
Yes, sir.
silicone oil re-RD under
Yes, yes.
with air
I think you have
infusion?
also tried to take it out. No, it's a nightmare. It's a nightmare. You can't. Don't mix these things together. Sorry. Please ask one more question.
So I wanted to ask silicone oil, like re-RD under silicone oil, can we manage these cases with air infusion? Like the ma'am mentioned silicone oil infusion. Similarly, if we use air in the infusion, can these be done?
No, the problem will be at the end, then you will have a hypofill.
No, and also there are two things. There get underfill, and also the visualization will become terrible. You have air bubbles, and you want to see clearly, so you won't be able to. Sorry. Yeah, interfaces. Yeah, there'll be too many interfaces. Yeah,
Yes,
thank
I
you.
read and somewhere heard, so I was confused whether to try this or not.
No, we
No,
don't
I think
recommend
with
it.
oil infusion,
We
it's
don't
very,
recommend
very
it
supportive, and the globe also
because
kind of
the oil will
forms.
become underfill, and then you get too many interfaces.
Sir, and I had seen some videos, international videos, where they use a very low infusion pressure
Sorry,
fluid.
I didn't understand.
They attach the infusion line and use a very low pressure, very low bottle height.
For
and
what?
do with that.
In what
The
situation?
same situation, sir. I'd seen a few videos.
But if you put infusion fluid with saline, then there will be underfill after that.
Yeah.
There'll be underfill, so I don't
That
think
is
that's a. Sometimes these videos you have to be very careful to see exactly the message.
So if fluid and air or whatever that you want to use to replace the lost oil will work only when it is a TRD configuration. It's a very small procedure. You just have to peel one membrane and end of story. But if you have to drain or it's a slightly more extensive thing, oil will be lost, so you need to replace it with oil.
Also, since the membrane peeling requires a very high degree of stereopsis and clarity, having 2-3 media, it will actually will be holding the retina and pinching it at many times, and the bleed will start and
Yes,
it will be
yes,
messed up.
it's correct. That bleeding is a big problem once it bleeds. Yeah.
I have seen few cases of recurrent detachment having PFO in situ for
Yes.
a week or 5 days. So, is it advisable or any added advantages are there or?
I do it as a routine. You can
Yeah,
leave
Dr. Abhishek
PFO
is very fond of this.
I do it as a routine. You can leave PFO for 2 weeks, 3 weeks, 4 weeks, nothing happens. There's no problem. The biggest advantage is the patient does not have to position, and if it's an inferior break, PFO does very well. You can leave PFO.
For how long we can leave?
The longest I have left is 6 weeks.
But I think recommendation, I think we should, at a forum, we should say around 2 weeks should be 2 to 3 weeks.
So
Dr. Steve
usually-
Charles has also
So
described
usually
this
what happens is
technique.
that, whenever you do laser, your CRA will form in 2 weeks' time. After that, anytime you want, you can remove it.
And after removing PFO, we need to inject oil or?
No, I just leave it with air. A routine FAE.
But if you're not sure of the retinal status, I would recommend you replace the PFO with oil, and then do the SOR after 2 to 3 months, if it's a very bad case. Especially if you're the beginner, I think Abhishek is master surgeon, but for all of rest of us, I think you should maybe replace it with oil. That's better, because you put air and then you have a recurrence, then you can be in a really bad situation.
Okay. And another question I would ask, are there any disadvantage or adverse outcome of peeling ILM at the primary surgery? If we see some sort of PVR A or B in peripheral area, or so it's.
There was a time when I was doing it for every RD case. Then I realized it's really not worth it. It doesn't add anything much to your practice. If you see significant number of ILM striae or some epiretinal membrane, fine. I still stain every case, and if I see that there is a membrane, then I will remove it. But now I've stopped doing it as a routine. The downside is, while doing peeling in a detached retina, sometimes you may cause a retinal break and then unnecessarily mess up things. So, do the minimum possible that is required to get the objective of a flat retina.
Yeah, sometimes less is more. Yeah. Okay, now we move on to the next talk on endophthalmitis. Dr. Abhishek Kothari, he's a VR surgeon from Jaipur, and he'll be speaking on this topic.
So I'd like to thank Dr. Reyes for including me in his IC, and I'd like to thank all of you for coming here on the final day and listening to us yap on. So this is something that all VR surgeons have to face, endophthalmitis. And a lot of our endophthalmitis doesn't come to us when it's in the beginning phase where you can manage with injection or a simple core vitrectomy. Sometimes it is quite fulminant. It's basically an SOS from the eye. I have no financial conflicts to declare. Now, what is fundamental endophthalmitis? It is that which is severe and rapidly progressing, either because of the virulence of the strain or because the organism is unusual and you're unable to, put a finger on and use the correct antibiotic. A lot of times with trauma and even with post-operative endophthalmitis, it is polymicrobial, and you get a result of one of the organisms, and you start treating along those lines and forget the other organism. Sometimes with the compromised immunity and drug abuse, sometimes in neonates, you get really bad endophthalmitis. We've all heard about, the post-Avastin counterfeit injections causing endophthalmitis, and these were really bad ones. And sometimes with traditional surgeries with large wounds, you get fulminant endophthalmitis. Now, before we go on how to manage it, first, let us look at the reasons why you get poor outcomes in these cases. If you have a highly virulent organism or drug resistance, then your job becomes difficult. If you have a late presentation or a delayed diagnosis, or you are not using specialist support or appropriate instrumentation or even diagnostics, you may have a delay in instituting the exact antibiotics. A lot of times, inadequate drug concentrations or control of inflammation causes more damage than the organism itself. And sometimes the complications that are left untreated at the time of surgery, for example, a retinal break or large ERM, that can cause problems. So the aims of treatment are to sterilize the eye to control the inflammation in this order. Sterilize the eye first, control the inflammation, and then address the comorbidities. Now, sterilizing the eye, it's best to know what you want to hit. So vitreous biopsy is always essential, and routine microbiology sometimes does not give us the answer. So I would strongly encourage people, whenever you have a severe endophthalmitis, jump quickly to PCR techniques because their sensitivity is much better than the routine microbiology. Always we order both. It's not that we do only PCR or only routine microbiology. Also, antibiotics, we use vancomycin and ceftazidime as a routine in all our cases, and Ampho-B at the first go, but if it's a severe endophthalmitis and has been treated earlier with these, have a very small, I would say, threshold to escalate. And how do you escalate? For gram-positive, you go to linezolid. It's a very, very effective antibiotic. For gram-negative, go to either piperacillin tazobactam, or my choice is colistin. And for fungal, you either go to voriconazole or caspofungin. So antibiotic escalation should happen early on if you don't get the response that you desire. Surgery, again, early, not according to EVS. If the media permits, if you have severe inflammation, if you have an increasing trend, or if the comorbidity like a foreign body or something like that dictates it, go for early surgery. You usually defer it only when you cannot do it. That is media opacity, you may have choroidal or some systemic factors. If you cannot do it, then wait. Otherwise, most of the times I would jump in. Controlling the inflammation is very, very, very important because sterilization is not alone responsible, to give you a good outcome. Macular edema, membranes, retinal detachment, and hypotony, all of them can result from inflammation. And vitreous acts as a reservoir for inflammatory mediators. So that's how early vitrectomy helps. I always induce a PVD. It's a controversial thing, but I almost always induce a PVD if I go in. And I use systemic and intravitreal steroids very frequently. Now, this is a very nice case. It has endophthalmitis with a foreign body impacted right next to the disc. So let me run this video. So this is what we usually do. The view is not almost always as great as you would have in a routine case. Most of the vitreous is cleared actually, and I'm running it from the point where you can actually see things. So don't be afraid. The problem with endovitrectomy is you cannot identify landmarks that easily. Sometimes what you think is a membrane may turn out to be retina, and what you sometimes think as retina may turn out to be a membrane. So you have to be very careful. Always have that orientation in mind, whether you're operating on the right eye or the left eye, and make sure you go along the routine expected landmarks. Collections of purulent material can sometimes appear as disc, and you may make mistakes. So here is we've reached the disc. All the vessels are basically sheathed, and there is collection. So I'm very slowly trying to peel and cut and peel and cut. And then I reach the disc. Once the disc landmarks are visible, very, very gradually, not like a routine PVD, holding it and just pulling it up. We do it a little more gradual fashion and along the retina. And my routine technique in severe endophthalmitis is to at least take the PVD till outside the arcade. I do not want to do it till the mid-periphery or to the periphery, just sufficient to, clear the posterior pole. Now in this case, there was also a foreign body impacted right under the disc. You see that hemorrhagic blob there, and of course you have to take the foreign body out. So initially I thought it's just the foreign body impacted there, and to remove it, I started inducing the PVD, and then I had a retinal break. Now this is the video that I'm trying to show. See, there's a retinal break and there's a bleed close to the disc. So this is something that, most of us would be really scared. And the reason I'm showing this video will become apparent to you. I still do continue doing things the way I would. One of the important things that I would like to stress in my talk is do not try to do everything in one go. You can sometimes do things in a, sequential manner also. So here I've basically cleared up all the vitreous. At this point of time, I've not found the foreign body. I tried scratching it with the tip of my cutter. So then I start exploring. It's there in the peripheral vitreous. So that was basically a ricocheted foreign body, which had created the break near the disc and then gone back. So this is the foreign body here in the inferior periphery. So this is also something which is difficult to sometimes locate in foreign bodies with endoff because of the peripheral thick white opaque skirt with with all the inflammation and fibrin. You sometimes can't find the foreign body. By the way, this is a phakic patient. So I'm using basically a handshake technique to take out this foreign body. And this is the end of surgery. I fill it up with oil. I do not want to do laser at this point. There is subretinal heme. So I will end up lasering a much larger area. So I fill it up with oil, treat it with postoperative intravitreals, dry out the inflammation and the infection. And this is how it progresses over time. With the oil, there's not going to be a detachment early on. After some time, you find that it is scarred, and then at that time, I go ahead and do off a laser, and then remove the oil later. And this patient is doing very well. This patient is 6'9". This is another of my favorite things that I do even in routine endos like post-operative endos when there is severe inflammation. You may have done a core vitrectomy, but the very next day or 2 days later, you still see that the media is mucky and you can't see much. So I do a 2-port lavage. This is a gravity-fed infusion in a routine IV line. The infusion goes in through a 24-gauge needle, and I just hold a 26-gauge needle at the opposite pars plana and let it drain for about 2-3 minutes. So this is basically to remove all the massive amount of inflammatory mediators. So this clears up the media very fast. At the end of this, I leave antibiotics in the eye. Anyway, I'm taking the patient after 48 hours into the OT to give them antibiotic injection. So I rather do a lavage and clear off the media to the extent possible. Sometimes you have to handle comorbidities like corneal issues, foreign bodies, etc. And one of the worst is the corneal issues. Sometimes you may have a wound that requires suturing. Sometimes you may have edema or infiltration or opacity. And in these eyes, sometimes we use a K-Pro. So this is a video of a patient who, again, a one-eyed patient who has a corneal opacity, or rather I would say infiltration, along with foreign body, RD, and ENDOF. So this is basically trephining the cornea, and then we put a temporary keratoprosthesis. For want of time, I will just fast forward it. This is a temporary keratoprosthesis, Landers. They come in both irrigating and non-irrigating varieties. You first put this on, and this gives you a fantastic view of the posterior. Then we start peeling off the membranes. This is all the organized vitreous that is there. This is taken care of, all the vitreous is removed, and then you can start seeing the retina. There is that foreign body lying there. The foreign body is also removed, and once all this is done, then that was the foreign body being removed, and then you fill in oil, and at the end, you use the donor cornea to put this, to seal this eye back again. Now, we almost always expect this cornea to fail, so you can do this with a grade B cornea. You don't need a very good cornea for this, because at the time of SOR, you usually will want to or will have to replace this with a better cornea. A lot of people, advocate complete extensive vitrectomy, and they say that it reduces the microbial load, it improves antibiotic excess, gives better kill, and the substrate for bacterial growth is removed. The math, if you look at it, even if you remove a lot of organisms and just leave 1 million organisms that is smaller than a pin tip, at the end of just 24 hours, when you see the patient again, there will be 1 billion organisms per ml. So you really, if you think that you're doing a vitrectomy to reduce the number of microorganisms, it's absolutely wrong. And oil or no oil, a lot of people in fulminant endophthalmitis put in oil at the end of surgery. If you have an indication, put oil. If you think that it is antibacterial, it prevents detachment, or it gives media clarity, no. These are not the indications where you should be using oil, because we've done an experiment where we created wells of agar similar to the size of the eye and filled them with silicone oil and put in the microorganisms, and they grew very well under the oil. See, this is Staphylococcus aureus, gram-negative organism. You can see the growth under the oil, and this is Candida. It grows fantastically under oil. So don't think that oil is going to stop anything from growing. Again, if you've created a break, oil is not going to prevent a detachment. You'll have to treat the break, otherwise the detachment is going to happen. So these notions, please leave it out of your head, that the worst thing that oil can do is all your inflammatory mediators will be outside the oil, that thin film, which will now hit the ciliary body and the anterior segment and will complicate your efforts in the long run. It can cause hypotony also. So put in oil only when it is required. And by the way, when you put in oil, then all your calculations of antibiotic and toxicity also go for a 6. You really don't know how much is the fluid compartment below it, and it's very difficult to handle. Multiple surgeries, this is my last slide. So multiple surgeries is something that I advocate in any bad situation, even in non-end-off cases. Sometimes you cannot achieve all your surgical objectives in one sitting. So whatever you can, do it. Maybe 3 days later, 4 days later, 5 days later, when the inflammation and the infection has subsided, you can go ahead and do the complete surgery. It helps in the way that you have a better view, lesser inflammation, and a more calm mind. Thank you so much.
Thank you. Any questions? I think sir is wanting to say something, and even we are, I think, wanting to say the same things.
Well, few more things I would like to add. We have done a thesis on endophthalmitis, early vitrectomy, and what our results were, the earliest, the better.
Yes.
EVS study was done 30 years ago on cataract patients. The results cannot be extrapolated to all cases of endophthalmitis. Never, I should say.
Quite correct.
And secondly, as Dr. Abhishek sir has shown, doing a PVD, inducing a PVD is very good. And the picture that we are seeing from the anterior segment, from the slit lamp, after removing the PVD, it might be a very good picture. And it might be, I should say, like anything, especially if it's our own case. And one more thing is, sir, you had yourself put an oil in a case. I think you were, in the case that you had induced a...
Yeah, because there was a break.
There was a break. Sir,
Yes.
why not PFCL?
Why PFCL? I mean, there is a break. I want to leave it for long.
Instantly it would prevent the bleed further. You can complete your surgery.
All bleeds stop. All bleeds stop. If the we always do a PT, APTT, and a BTCT. So all bleeds stop. Very few bleeds
It's an inflamed
continue.
retina, sir.
Yeah, it's an inflamed retina. So the only problem that has been talked about after leaving PFCL is inflammation. So I don't want to leave something that can possibly cause inflammation in an already inflamed eye.
Achha.
So there is a break. I would want to leave the tamponade for long because I want the subretinal blood to go away. I want it to fibrose and and become shrunken to one small area that I can laser.
So the patient will be
Prone.
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 I think the main indication for PFC in all these cases are recurrent inferior RD, where a patient can't position in a prone fashion. That should be one of the only indications for using PFCL as a endotampered long term, because it is not approved also. This is something
Not long term, sir. I'm speaking about the peroperative.
I
think when you had
just
the
for
bleed,
the intraoperatively
just to
you
stop
can
the
use it.
bleed,
Yeah,
you
at that point is fine. But Dr. Abhishek
Yeah, so
understood your
if
question
it-
that you want to leave PFCL.
If the bleed had not stopped, I would have considered it.
Yeah.
The bleed stopped.
I think he misunderstood. He thought you were asking that why did you not inject the oil with PFCL and leave it like that, close the eye with PFCL in it.
So here the bleed stopped and the retina is not detached.
And
So-
one more thing is, as Dr. Abhishek has told, that the silicon globule is there, and if the patient is erect, all the microbial load is inferiorly. If the patient is lying supine, it's close to the macula, and if it's lying this side, it's here, and the central portion is saved, and all the organisms, the load and the inflammatory material and everything, the toxins, they are actually circulating very close to the retina, actually in touch contact with the retina.
So there are
Silicon
there are
oil. In
MRI
that
studies.
case, the eye was lost, and the patient
I-
will be presented with scleral necrosis.
We have used, and I think this is good that you've shown, but if you do literature search, there are actual publications in retina. There's a publication EGO, and they have shown that it has antimicrobial, and these are standard publications in retina journals. So I think we have to have a balanced view because this is an instruction course. But
So I'll tell you
this
what.
is his
So what
experience.
happens with oil is that there are MRI studies on RD patients, not even end-off patients, where they've estimated the amount of oil after a retinal surgery, and the fluid compartment. So it varies from 0.2 to almost 1.5 cc. And these are cases where you had clear visualization. End of visualization low, how much you are going to fill, how much is going to be residual, you really don't know. And after that, when you start putting in the antibiotics, you have no idea as to what the final concentration is going to be.
I think Dr. Dhaneshi can come on to and put up her slides, and we can continue the discussion after the. Okay, while ma'am is putting up her presentation, we can have one or two questions. Abhishek can come and be on the panel.
What is the role of systemic antibiotic in this?
So this is a very good question, because when the EVS study was published, those antibiotics which were, I think we discussed in that other thing also, antibiotics used did not have good intraocular penetration. But what you have to remember now, moxifloxacin has very good penetration, intraocular penetration. So what we do is we start the patient on moxifloxacin 400 milligram BD, these end of patients. And I mean, we've not done any clinical trial, but we feel it helps. And it is known that it's much better than using the oral antibiotics.
So linezolid is an antibiotic that even in non-inflamed conditions, one single oral dose reaches the reaches concentrations of more than MIC 90 for most of the gram-positive organisms. So it works even for MRSA. So that is only for gram-positive though. And ciprofloxacin also penetrates. Voriconazole via the oral route does reach into significant amounts in the eye. So those are the three you can use orally.
Choice of antibiotic for traumatic endo.
So
Take that question after ma'am's. Ma'am is speaking on trauma, so we'll take that after ma'am's talk.
Okay, so good morning. First of all, I would like to thank the Darius for this kind invitation. So I am going to talk to you about extreme trauma. Trauma can be quite challenging and quite daunting to many surgeons. Even after years of experience, it can still be challenging to manage an extreme trauma case. So a few tips and tricks for managing extreme trauma. So it would be good to familiarize oneself with this new trauma terminology and the classification. Basically, it is based on the zone involved, the pupillary reaction, the visual acuity, and it is divided into open globe and closed globe. So this is useful because this will give a uniformity to your classification and better to analyze the cases later. So even before you do primary repair, you must look for any other associated injuries, check the patient's vital signs, and look for bony injuries. Now, in case of unstable vital signs or impaired mental status, or if they have other serious non-ocular injuries, so these things should be dealt with first. So, shift the patient to the concerned hospital and let them be stabilized. After that, you can do a primary repair. So, patient of trauma comes to you, take a quick history as to the circumstances of the trauma, then do a quick examination. If possible, you can also do a slit lamp and binocular indirect ophthalmoscope, but if not, at least an external examination can be done to look for any open globe or foreign body. In case these are present, then the immediate intervention such as surgery will be required. But in case there is uncertainty about this, an imaging is a good option. And after imaging also, if there is uncertainty, you can either explore or can observe further. So what is the timing of vitrectomy? Almost all cases of extreme trauma require vitrectomy, and the timing is a little bit contradictory. There are contradictory views about this. Whether it should be done at the time of primary repair. The pros for this is that there is no fibrovascular proliferation at this time, and there is a less chance of infection if you operate immediately at the time of primary repair. But the cons are that there is poor visualization, the tissues are edematous and inflamed and they bleed very easily, so it's difficult to handle the tissues, and also there is inability to assess the damage fully. So it would be better, so this is one example. You can see the ultrasound on the left side. You see a lot of disruption in the vitreous cavity, and it's really difficult to make out what is what. And the same patient, after 10 days of waiting and with some amount of steroids also be given, you see there is a beautiful clearing of the vitreous cavity, all that suprachoroidal hemorrhage, choroidal inflammation is all settled down, and you see a shallow detachment. Now this is a situation where it is easy to deal with this patient. So sometimes it is good to wait for vitrectomy and not rush in at the time of primary repair. However, there is always a possibility of developing fibrovascular proliferation in all these open globe injuries, and the risk is higher when there is a vitreous incarcerated in the wound, and in the presence of say blood or lens matter, these chances of fibrovascular proliferation is higher. So fibrovascular proliferation can cause a focal tractional detachment as a kind of a band extending from the wound to the posteriorly, or it can have a circumferential membrane causing a peripheral retinal detachment, or it can also have a cyclitic or a pupillary membrane. So the indications for early, late and delayed vitrectomy are: for early vitrectomy, that is within 72 hours, the indications are endophthalmitis or a toxic intraocular foreign body or retinal detachment. For late vitrectomy, that is between 3 and 14 days, the indications are retinal detachment, lens or vitreous injury, severe vitreous hemorrhage, double perforating injury or intraocular foreign body. And delayed vitrectomy, where you don't need to immediately intervene, that is beyond 3 weeks, are pupillary membrane, dislocated lens or ghost cell glaucoma, retinal detachment with PVR, macular pucker or vitreous opacity. So how do you do preoperative evaluation is very important. The assessment of perception of light is important in most of these badly traumatized cases. Sometimes you may have to take help of probably electrophysiological tests also. but often it would be better to go ahead with surgery even with perception if it is not known. I will come to that a little later. An informed consent is very important as to the visual guarded prognosis as well as multiple surgeries which might be required. Assess the associated injuries and also anterior segment. Look for any media clarity, or if there is any necessity to plan for cataract removal or iridoplasty, penetrating keratoplasty or SFIOL, and then you do the posterior segment assessment. Now, imaging has a vital role in trauma. It gives you the retinal status, whether it is attached or detached. It can also determine whether there is a posterior globe rupture. The vitreoretinal relationship is very important to find out whether there is incarceration or how the vitreous attached. The presence of IOFB is absolutely important, whether the patient has dislocated lens or IOL and choroidal detachment. Now, all these details will help you in planning of your surgery. It will help you in getting your instruments and the operation theater ready. Many times you are operating in odd hours of the day, and it is most important for prognostication. So these are just examples. You can either do an ultrasound, and even in a badly traumatized eye, you can do a gentle ultrasound, which is easily available to you, and it can immediately give you information about posterior segment. Sometimes a CT scan a patient can be referred for a CT scan, and especially for bony injuries or foreign body. Metallic foreign bodies avoid MRI, and CT scan is the most important. So general principles of surgery, if you have, this is just an example to show you even in a badly traumatized cornea, sometimes you can have a good view. So you can go ahead with the surgery. However, before you start surgery, look for the wound integrity. Even in, sometimes if it is a 7 to 10 days old wound, sometimes they can leak, and check for leakage of the wound. And if necessary, you may have to resuture them and make the globe watertight before you proceed with your vitrectomy surgery. Sclerotomy planning is most important in a traumatized eye. So avoid the sites of trauma for your sclerotomy placing, but the sclerotomy should be placed in such a way that there is an easy access both to the wound as well as to the posterior pole. Now, where to place the infusion cannula is also very important. Again, avoid the quadrant where the injury is there, especially if it is extending on the sclera and beyond the muscle insertion, then those quadrants should be definitely avoided, because 100% there would be a vitreous or retinal incarceration in those sites. Again, choose the area where there is minimal choroidal detachment. A 6 mm infusion cannula will be preferable. In case the cannula is not visible, then either an AC maintainer or a bent infusion cannula can be used for initial vitrectomy till such a time that your cannula tip is visible. This is one patient where you have almost 180 degree of inferior wound which is sutured, and there was vitreous and retinal incarceration inferiorly. So I have placed an infusion cannula at 12 o'clock. So these kind of changes can be done to make ease of surgery. And this is a situation where we have placed an AC maintainer, because although the infusion cannula is placed, but that was not visible. So shifted to AC maintainer, and the initial vitrectomy clearing of the media is done, then you can go back to your pars plana infusion cannula. This is a 20 gauge MBR knife being used, and many times when you do the sclerotomy, you will see this egress of this blood tinged suprachoroidal fluid. So this is very important. Oftentimes in trauma you will have this, and once this fluid is drained, it will be easier for you to place the infusion cannula and also visualize the tip. So maybe I'll just go a little bit ahead. And so once you start the vitrectomy, you will see that it is so difficult inside to make out which is the vitreous, which is the retina, and it is just even so. I have used the chandelier here, and with bimanual technique, again it's very difficult. So you have to be very cautious and not cut any tissue unless you know that this is not the retina. So be very, very careful, and you will see this is the retina now after about 2 to 3 hours of dissection and struggling with that membranes. You can see now this retina is somehow settled. Okay. Posterior vitreous detachment is a very important step, and I would recommend it for all surgeries, because if you leave any residual vitreous, that is bound to contract and lead to fibrous proliferation and a recurrence. So it must be done. However, it can be difficult in young children, and also if there is a pre-existing fibrosis and retinal detachment, it can be difficult. Now this is a situation where retina is detached and there is vitreous hemorrhage. Also there is no PVD, and it becomes very tough to kind of induce PVD or remove the PHF in this situation. However, it must be done very cautiously. You can do kind of try to do some shaving in the beginning, and once you are certain about the retina, then you can try to remove the PHF. You can either use the cutter or even forceps for that. Now, vitreous or retinal incarceration, this was already spoken to in his talk by, in the Dilraj's talk by Darius. If you have a vitreous incarceration in the wound, do not pull that vitreous out. Leave the vitreous plugging the wound, and often if it is an old wound, it cannot be even pulled out. So leave it, but trim it as close as possible to the wound. And if there is a mild retinal incarceration, then again this can be left there. If you want, you can barrage the area with laser and support it with scleral buckle. But if there is a severe incarceration causing a lot of puckering and pulling the retina around it, then it is best to cut the retina all around this site of incarceration and do your PFCL laser and silicone oil, etc. And these are situations where the large retinectomies have been done around the areas of retinal incarceration, and this actually allows the posterior retina to settle well, and you may still have good visual outcome despite a bad retinal incarceration. A word about intraocular foreign body. About 18% of posterior segment trauma have foreign body. Foreign body can be either reactive, such as iron or copper, or it could be a non-reactive glass or plastic, and sometimes even vegetative matter. Most important indications would be, the considerations would be a location of the foreign body, the nature of the foreign body, and route of the foreign body removal. This is a small algorithm which tells you that if you have a foreign body in the vitreous, remove the vitreous around the foreign body first before you remove the foreign body. If it is a magnetic foreign body which is less than 5 millimeters, you can use it, you can remove it through the sclerotomy, but enlarge the sclerotomy, and you can use a handshake technique with both magnet and a foreign body forceps. If you have a non-magnetic foreign body or a very large foreign body, then it is better to remove it through the limbus. Sometimes a clear lens has to be sacrificed for removal. In case the foreign body is on the retinal surface and if it is encapsulated, there is no need to remove the capsule. You just cut the capsule over the foreign body and tease the foreign body out of the capsule. Oftentimes this capsule is very adherent and it is impossible to remove it from the retina. So best is to leave the capsule. It can either get dissolved or can get organized into a fibrous envelope. If there are any retinal holes around the foreign body, then those should be laser first before you try to remove the foreign body. And in case the foreign body is a subretinal or in ocular coats, sometimes it would be better to do a posterior approach, that is go from outside, cut the sclera over the foreign body and remove the foreign body from outside. And you may have to put an encerclage or a buckle at this stage. So these are two extreme cases of foreign body removal where there is a large bullet which is being removed in an open sky manner by doing PK, because obviously there is no other way to remove. So you can see this. And this is another situation where primary attempt elsewhere was failed, and this is again second time we are attempting to remove a glass foreign body, which was like a cuboid foreign body, very large, and very difficult to hold this foreign body with, even with the largest forceps was difficult to hold, but somehow you could hold the foreign body, and this is now removed through the limbus. So you can have this kind of a handshake kind of a technique and remove the foreign body. Suprachoroidal hemorrhage is often present in extreme trauma. Almost similarly, it is better to wait for 2 weeks for the clot lysis and then take a call and further, course of action. Systemic steroids are definitely helpful in controlling the situation. Post-traumatic endophthalmitis, I will not go into details because Abhishek has already covered it. The risk factors for post-op endophthalmitis are delayed primary repair beyond 24 hours, presence of foreign body or ruptured lens capsule. So it is, if you suspect endophthalmitis, it is better to do the wound repair at the earliest. A word about the no light perception eyes. So oftentimes you have extreme trauma with no perception. However, before you do anything for these eyes, rule out these three things. One is optic nerve avulsion, optic nerve transection, or profound loss of intraocular contents. Now, in these three situations, there is nothing can be done, and it is best to leave these eyes alone. But otherwise, sometimes visual recovery can occur even in those so-called no PL eyes, because the no PL can be because of impaired cognitive state, or sometimes in children. Sometimes dense hyphema, vitreous hemorrhage, choroidal hemorrhage, or retinal detachment can also contribute to the so-called NPL status. About 4 to 33% of patients have been shown to recover some amount of vision, but however it would be best to take a call based on case-to-case decision to see whether such a case should be intervened or no. So the takeaway points would be extreme trauma is often a less than ideal situation, and there are many challenges. Improvisation is necessary, and oftentimes you have to have a plan B ready. Expect the worst and always try to save the globe. Never do a primary evisceration or an enucleation. Always try to do a wound repair and see how much of the eye can be salvaged. Best time to intervene for retinal surgery is about 10 to 15 days following the trauma and the wound repair. However, the outcomes can be quite varied, but sometimes the useful vision can be salvaged. So thank you very much for your patient listening.
Thank you. Thank you. That's excellent talk and covered all the aspects. I think we had a question from ma'am at the back, so we can take that question now. Okay, and after that we'll conclude the session.
So, choice of antibiotic and traumatic endo. Do you differ with usual ceftazidime, Venco, and
Usually, if really depends upon the history of what kind of a trauma it is. I very frequently do give voriconazole and moxifloxacin intravitreal. And I call it V plus V, voriconazole and Vigamox, and because that gives you a very broad spectrum. Vigamox has an excellent gram-positive and relatively decent gram-negative coverage. And it is active against the Bacillus species also, which is very common in trauma. And for the fungal aspect, voriconazole does cover. If it, in the meantime, if I'm sending a sample and it comes out, with something, then accordingly we change the antibiotics.
yes, and sir, IFB removal, limbal route, and if we create scleral tunnel route, so which will be preferred, or pros and cons of both?
Again, depends upon the size. If it's a small foreign body, then the limbal route itself is fine. It's a smaller one. If it's a really large one, then it's preferable to create a scleral tunnel because of the the problems with the large corneal incision.
Ma'am, any size you take for the which route, like she's asking?
If a large foreign body is larger than 5 millimeters, you have to give a very large section. So scleral tunnel may not be possible, but you can always try. Again, depends on the shape of the foreign body. If it is a linear foreign body, it's easier to take out through a small tunnel. If it is a large like this cuboid, a very irregular foreign body, then it would be difficult. Best is to give a large section and then remove it.
Yeah, and sir, I faced with one case of retinal incarceration, and there was fold like from anterior to posterior. So then, being a beginner, it was tough for me, and I was no way to do that surgery. So how you manage if there are vertical, horizontal folds? From where to do retinectomy in these cases?
No, not all folds need to be cut. If there is a peripheral fold which is not, in no way interfering with your posterior pole, it allows your posterior pole to attach, you can just ignore the fold. Maybe just do some laser around it if you are worried about it. If the fold is interfering with the retinal reattachment, or if it is in the macular area, then you need to address the fold. In that situation, first you try to remove the membranes around it and surrounding and see whether the fold is flattening. Maybe try to use LPFC. If not, then only cut the retina. So better to cut the retina as far peripherally as possible, so as to try and save more posterior retina.
You can try putting in, if it's a detached retina also, then you can try putting in PSCL. And as you subsequently add PSCL, the retina will keep straightening out, and there will be a point where it will not straighten out further. That is that point where you do a cautery and cut it.
So sometimes as a beginner, when we use PFCL, then we always fear of leaving small bubble, and post-op we see PFO. So tips to be sure, and which instrument you prefer to be, which will be easy as in.
The best way to not leave PFO or not have the subretinal PFO or have PFO related complications is to minimize turbulence. Most of the times the PFO breaks into small bubbles and goes here and there where you cannot see it when you have turbulence. So always use good quality walled cannulas, then you usually will not have problems.
And on the Constellation system, you can put this compensation off. There's a way you can put the compensation off.
Active infusion off.
And another thing is that one of the very it's not described in literature, but the best way to remove all the PFCL from the eye is to let fluid air exchange run for some time while you're doing your laser, the last part of the laser. Because PFO is extremely volatile. It will all evaporate. It will evaporate very fast. So that is also a technique. Then, all the PFO goes away. You will not have a residual PFO.
Thank you.
It is regarding fulminant endophthalmitis. I have a question. If we are not able to get the results on microscopy, how does vitrectomy helps? Because if some residual bacteria or some fungus remains there, is it going to help? And second question is, what is your take on using steroids intravitreal?
You always have to use steroids. In fungal, you initially do not use steroids till you achieve sterilization, but in bacterial, you almost always have to use steroids. As far as the clearance is concerned, you can never clear. You can absolutely, in no circumstance, you can completely clear the infection. The infection is going to be cleared by the antibiotic. It's the vitreous and the debris and the inflammatory material that is going to be removed by the vitrectomy. So if you have to first remove that mindset that I'm going to clear the infection with my vitrectomy. It's never, ever, ever going to happen. It's the effective antibiotic that is going to kill the organisms.
What's the best possible combination of antibiotics or antifungal you use if we are not able to get the results on microscopy?
So then in a post-operative case, I would use vancomycin, ceftazidime and voriconazole in the first go. If it is hyperacute one day, then probably only the antibacterials, but let's suppose if it comes at 10 days, I'll use all three.
Thank you, sir.
I think we'll come down and we can discuss because they are sending us the message that we have to conclude. Thank you so much. I'd like to thank co-instructors. I think we had a very small audience, but a very involved and very interactive session. So that was really nice. Thank you. Thank you for being with us on the last day of AIOSC 2022. Thank you.